Hello, everyone. Welcome to this APHRS Young EP webinar. So this is the first initiative of the Young EP.
Your audio? I think we're losing the
Welcome you
audio.
all to this meeting. And today we are aiming to learn by a case-based approach. And the objective of this webinar would be to learn core principles and high-value principles of electrophysiology using a case-based approach, which is, in our opinion, more effective sometimes as compared to didactic lectures. So we have three presentations today. And to take us through this session, we have two senior, very eminent chairpersons. Let me welcome Dr. Tachapong Ngarmukos and Professor Kyoko Soejima from Japan. And Dr. Tachapong Ngarmukos is the president of the Asia Pacific Heart Rhythm Society, and we are very privileged that he has taken the time to join us today. He is from the Ramathibodi Hospital in Bangkok, the Mahidol University, and the current president of the APHRS. I invite Dr. Tachapong now to just say a few words.
Well, first of all, I would like to thank Dr. Narayanan, Dr. Martin, and Dr. Chung to actually help creating this webinar. Actually, even before things happened, we were talking about doing something like this for APHRS for young persons, so we get more interaction, not only during the meeting, but throughout the years. As it turned out, kind of the COVID helped us kind of make things happen a bit faster. I'm a little disappointed. I thought I was invited because I'm young.
Of course you are.
I thought I was I'm among the young EP groups. As it turned out, no, I'm the senior person. So I hope this is the first time we actually doing this on our own without the help. So Jimmy, our secretary team, and Corinna has been working on these things to get things going so we can meet more often, doing things that are a little bit more, I guess, a bit relaxed, but educational, not too formal. So maybe we can learn more things this way, hopefully. And with me, I got my friend, Professor Soejima, which on that side on my thing. So Kyoko, please.
Oh, no, I think Kumar is going to go first, right?
Yeah, I'm just going to give a brief introduction. We have the
okay, great. Oh, yes.
Professor Kyoko Soejima. Thank you for joining us, Professor. And she's a professor at the Kyorin University and the chief of cardiology there. So again, we are very privileged and fortunate to have her with us. So a few words from your side, Professor.
Yeah, thank you. Thank you for having us as a chairperson. It's great. Same as Tachapong, I thought I was invited for the session because I'm young, but guess it's not.
Of course.
So I think a little bit disappointed that we are not meeting in person as usual, but because of the COVID-19. But as Tachapong said, I think we have to change the custom, we have to change the gear to have the meeting and also academic activity through the website. And it's a great honor to host this wonderful like young EP sessions. And this is a good start for the APHRS. And I hope everyone who's listening to this webinar is going to learn and also enjoy the session. It's a very good honor. Thank you.
Thank you. I request actually now the chairpersons to take over the
sure.
and to go ahead with the presentations.
Okay, so first speaker we have today is Dr. Chung from Taiwan. He's a good friend of mine. He's a cardiologist, electrophysiologist at Taiwan Veteran General's Hospital, Taipei. He's a director of the Southern Cardiac Death Program of Heart Rhythm Center in Taipei, VGH. His research interest includes atrial fibrillation and ventricular arrhythmia ablation. Has collaboration with a hospital in the United States and Poland for the researchers. Dr. Chung, please, he's going to present a case presentation of VT.
So thanks for Dr. Kyoko's introductions. And I had the privilege to present my cases. I prepared 2 cases, but I'm not sure that I could go through all the cases of the 50 minutes the durations, and this is my slides. And the first one that I want to introduce is the cases that I performed in Myanmar a few years ago. This is the 58 years old man with the ARVC diagnosis with the left ventricle, the left bundle branch block pattern, the ventricular tachycardia with the superior axis. So this is the subject characteristic of the epicardial site, because in this patient we have the endocardial substrate mapping, but we found that there is no any hotspot area that we have the interest. So we move to the epicardial. So you could see that in this patient that the epicardial site, we could identify the abnormal substrate in the epicardial originated from the alveoli area and also the RV basal area. So you could also see the isochrome map in this patient. You could see that there is a 2 hotspot area that just encircled by the red color circles. That you could see that is one isochrome crowding area within the alveoli area, and also one is the close to the tricuspid annulus area. So just like this area, but in this case, because in that time we didn't have the navigation of the magnet system, so you could see that there is some torsion of the geometry shape. So this is a very beautiful epicardial that when we map the basal inferior of the right ventricle area, you can see that the very late potentials that we can identify by the decapolar clusters. So this is the first questions. First of all, I want to pass the questions within the room. Sorry for interruptions, and I'm not familiar with that.
Dr. Chan, are you okay?
Yeah. I want to just skip that because this is the first question that I raised for the audience, but currently we only have the audience from the Young ED committees. So this is the first question that I want to raise, that this is the epicardial mapping by the dual decapolar clusters, that when we want to try to ablate it, you can see that that is a very beautiful question. That is a very beautiful signals that we could record it from epicardial. And even that we have the very late potentials within the epicardial, but you can see these 2 components of the epicardial. So I move to the question 1 is where is the site of the A of the VT isthmus? Probably
we are allowed to vote.
Yeah, currently we didn't have too much participants, so I will move to the questions as well. So of course, you can see the cycle length of the tachycardia is the 348 milliseconds, and you can find that the 2 components of the, for example, just like the duodeca 2, you can see that the loss of the second component of the duodecapolar clusters, which means that it's not possible in the circuit, just like in this case. And if possibly if it major in the VT circuit, it means that probably that it will be very close to entrance, but definitely because you can see that the loss of the second component of the potentials, which means that it's not in the circuit at all. So how about the second component of the spiky potentials of the B? It's very interesting because we try to emphasize that this is very important. We try to emphasize it possibly that part of the epicardial mapping is a part of the circuit in this case. So because during the VT, we have tried to do the activation map of the epicardium and endocardial, and we could find that there is the centrifugal pattern of the VT for both of the epicardial or the endocardial. So you could see that in these potentials, you can see the spiky potentials is very important. For the tachycardial cycle length, it's around 348 cycle length as what we measured in previously. And you can see that it's just like the wobbling of the spiky potentials, which are around 338 to 348. This is a very big change of the spiky potential. You can also see that this is a very tiny far field potentials that we could record it by the dual decapolar cluster. So it means that for these potentials, it possibly could be not in the circuit. So therefore, we have advanced. This is the most important tracing that I usually show this tracing for my fellows to teaching how to measure the entrainment. So this is the entrainment because originally that when we try to have when we have this tracing, when we initially tried to do the evaluation from the epicardium, so therefore we advance the ablation gaster to the same size, close to the probably to the 6th or 9th, and we try to identify the potential interest area, hotspot area that we could target to terminate the VT. So this is a very interesting tracing. So how about the tracing of the entrainment? This entrainment is very interesting because a lot of the, even for my fellows, a lot of the fellows will interpret that the tracing to be the very good capture. I think the majority of the EP doctors will interpret that to be the concealed entrainment of the tachycardia, because you can see that definitely that during the pacing that the cycle length was shortened. And you can see that very interesting is that a little bit cycle length, and also you can see that a little bit the morphology changes during the pacing. For example, just like precordial, the V1 and V2, you could see that the V1 and V2 got a very high of the for the R wave potentials compared with the precordial list of the second beat or the fourth beat. And very interesting is a lot of the doctors will interpret that this tracing to be the capture at immediately at just the capture out of the QRS morphology. But actually, if you take a look at the end of the pacing cycle length, you can see that there is a very long, if you consider this is only 33 milliseconds precede onset of the QRS, and you can see that this is a very strange thing that that is the tachycardia is not consistent with the cycle length, because you can see that the cycle length changed from the 392 to the 375. So it means that something must be missing in this tracing, because that's probably that is the pacing of this beat result in this activation of this beat. This is a very, very, very long activation of the S to the QRS in this case. So you could also see that in this case, you could see that from the previous beat, that S2 to QRS is the same as the next bit is the almost to the 400 milliseconds precede of the QRS. So which means that it's more likely to be the adjacent bystanders. However, if you look at the local signals, it's also very interesting because when you look at the local signals, you can see that for the spiky potentials, just like Dr. Kyoko's publication, you could try to look at the adjacent casters recordings. You can see that in this bit, this spiky potentials was just on the S wave of the QRS. However, in this bit, you can see that these potentials could be recorded almost at the onset of the QRS. So when we look back to the original recording at the sinus bit, you can see that actually we have the two components of the potential that could be recorded at the dual theta polar caster. So it means that probably that is owing to the anisotropic conduction of the electric grounds within the adjacent structures that result in the inconsistent electric ground recordings from the ablation caster. Of course, the ablation caster is not a good caster for the electric ground identification. So in this case, therefore, we identify that the epicardial substrate is not particularly in the circuit. So we move to the endocardial sites because the endocardial site, for the majority of the endocardial sites, also shows the centrifugal activation pattern. So therefore, we recorded at the corresponding site. We could find a very tiny, and you could also see the atrial activation potentials could be recorded at the sites, and you can see a very beautiful dielectric potentials. So my question is for the question is where is the location of the seed? Because a lot of doctors will consider this definitely to be the dielectric activities, looks like to be the mid-dielectric potentials, but actually if you measure the tachycardia cycle length is the 348 milliseconds. So if you try to measure the dielectric activities of these signals to the onset of the QRS is almost to the 108. It means that it almost to at the 30% of the activation. So it means that even for these dielectric activities, we only get almost to be a seed of the ventricular tachycardia. So therefore, we prove this to be put on the RF energies. You can see that the very quick termination of the tachycardia, and this is a very beautiful tracing because you can see that even after the termination of the tachycardia, that the dielectric activity is still there, just like when we do the WW ablations, you can see it almost blocked almost at the exit site of the tachycardia, and it didn't go to the ventricular tachycardia again. So how many milliseconds? How many seconds did I take? Do I have adequate time? Do I have adequate time for the second case?
Jimmy, how is it time-wise? I think you probably have a few minutes.
Yeah, you can proceed, I think.
Yeah. I would because I didn't prepare a question for a second case, but this is a very interesting case with the non-ischemic cardiomyopathy. This is a very tough case with the concealed WW receive ablation before, and also have the atrial fibrillation, ventricular tachycardia. This is the drugs that we use, the medicines that we use for the case, and also the echocardiography shows that the ejection fraction was almost to be normal, though that some portion of the left ventricle is not well. And this is the MR that we developed for this case. You can see the very beautiful left gadolinium enhancement by the MRI. And you can see that this is the reconstruction, and from the radiologist that the origin told me that possibly that the channel will be close to a lateral basal area of the mitral annulus. So this is the case that we did the right ventricle, and also the you can see that even from the right parahesian region, we could see some spiky potentials. I can show you that very beautiful ones, like just like in this case, you can see a very long, prolonged that the late potentials recorded from the right parahesian regions that and also you can see that the baseline, you can see that the H2 onset of the QRS already prolonged, which means that the nodal function is not good in this case. So we also try to map of the left ventricle. You can see that the clotting region was close to the basal region, very close to the left bundle region. And you can see that actually in this case have some conduction abnormalities, but didn't brief to the right bundle, left bundle branch patterns. So in this case, we just have the target, and this is a very beautiful trace. You can see that just in the positions we recorded the his potentials from the left side. You could also record the diastolic activities at the left side. So this is the case that we try to use the two functions, try to identify the late activations as well as the earliest activations. You can see that the relatively late activation in this case with the isochrone clotting was just located at the area with the left bundle branch insertion. And this is the VT that we try to induce. We have the several VTs in this case. This is the first VT which was mappable in this case with the left bundle branch block activation pattern, and also with the inferior axis. And this is a very beautiful isochrone map of the VT. You can see that the isochrone shows the channels just identified close to the left bundle region. So also for the majority of the diastolic activities that we recorded, even from the for the VT1 or the VT, for example, like the VT2, actually you can see that the diastolic activity is very tiny. It means that probably that it comes from intramural regions, and also in spite of we could record a very interesting electrograms here from the A1 and A2. Actually, it's almost at the onset of the QRS. So we also have the VT3 and the VT4. Even for a VT4, we can see that this is a very tiny diastolic activities here. So we have several times that once we put on the allergies that the VT was terminated, but the VT was recur again after we put on the infused with the isoproterenol. Therefore, we decided to use the bipolar ablation for this case. So this is the tracing that we try to use. You can see that almost at the onset of the QRS, you can see that the termination of the QRS during the bipolar ablation, but actually you can see this is not within the diastolic phase for this VT. And because in this case that the patient originally didn't receive the ICD implantation, so the patient didn't want to sacrifice the AV node as the first time procedure. So however, after ICD implantation, the patient still have the several episodes of the VT recurrence. So we intended to encourage the patient to receive the second procedure of the VT ablation. So you can see that the second time that the VT is definitely different from the VT1 that we induced during the first procedure, which means that probably we have changed the state of the VT isthmus. And you could see that the very continuous activation of the during the ablation catheters of the right ventricle, the left ventricles, which means that probably that the right ventricle will be more close to a circuit entrance. So when we put on the energy that the VT was terminated, however, when we have several trials of the VT ablation, that the VT still could be induced unless we target the area with the left bundle regions, which will also result in the complete AV block. In this case, you can see that the VT was terminated with the complete depends on the pacing, and also sometimes the potentials could be recorded at the ablation caster. Okay, so this is my presentation. Thank you.
Great case. Thank you. I think it's very important that you showed the importance of entrainment mapping. And also so for the second patient, I think this patient was very challenging. Non-ischemic cardiomyopathy has a multiple morphology of VT, 2 being a left bundle and 2 being a right bundle, and looks like it's a very deep in the myocardium interventricular septum. This patient had non-ischemic, right? Any chance of him having cardiac sarcoidosis? And
yeah, we have title biopsy for this case, but actually in this case we only found the fibrosis, but actually we have no evidence to prove that it is the sarcoidosis, or for example, just like Lamin cardiomyopathy in this case.
I see. And also I think it's very challenging. We know that we are very close to the conduction system. And in this case, I don't know, if I were you, probably I would have chosen CRTD instead of drug chamber ICD. What would be the choice for you in this patient? Because I think you know that the patient is going to be dependent to do a lot of ablation.
Yeah, I totally agree with you. And also we have connect with this patient. I mentioned about to this patient about the possibility of the left ventricular function deterioration after depends on the pacing. So therefore, we didn't try to sacrifice the AV node at the first section. So and also that the patient didn't agree with to the sacrification of the AV node function at the first section. That's why we have we need to proceed the second procedure for this case. So because the VT occurrence, the frequency of the recurrence is too frequent, that therefore we need to proceed the second procedure for this case. And we believe that the frequent recurrence of the VT could also deteriorate the functions. Therefore, we go to the second procedure for this case, and we hope that and we also prove that in this case that during the follow-up period that the heart function get improved, because that less of the VT recurrence and also the less ATP terminated VT in this case. So I agree with you, Soejima, that in this kind of cases, possibly that the CRTD will be mandatory in this kind of cases in the future if the heart function gets worse.
Okay, great. I'm sorry. It was supposed to be that Tachapong supposed to chair this. I'm sorry.
No. It's perfectly fine. No, actually, for VT, SCAR VT, entrainment mapping, it has to be the diva. So, you know, I'm one of those guys who just map and ablate. So I'm actually good that you did the. No, I think it's great case. Those cases are great, you know, with all the, you know, all the entrainment mapping, all the detail map, all those, how to read those electrograms, which part they are coming from. And the ablation was, I have to say, it's perfect. It's perfect. It looks great, Papo. Congratulations on those. So now I guess it's my turn.
I just have some comment from Soejima for the entrainment.
Yes. Yes, he's the diva of entrainment, of VT especially.
Because you are a god of the entrainment, right?
Yeah.
All right.
All right. So now I guess the next, my turn. I'm going to introduce Andrew Martin. He's from New Zealand. He's the consultant electrophysiologist and cardiologist in Auckland City. In New Zealand. He trained there and also in Freeman Hospital in Newcastle, England. his interest including adult congenital heart disease. That's very interesting, and inherited cardiac disorder. Hey, Andrew, how are you?
I'm well, thanks. Thanks, Tachapong. I'll just go onto my share screen.
All right.
Great. I hope that's working. So thank you very much for the opportunity to speak. And I think this is a great format to bring us all together in these really challenging times across the globe. So thanks again for the opportunity, and also to Jimmy for organising things for us. So I'm going to present two cases of atrial flutter that occurred following cardiac surgery, and really aim to try and provide an approach to ablation in these sorts of circumstances. As part of that, I'm going to try and reinforce and talk more, I guess, from an anatomical perspective about how really important it is to understand exactly what the surgeons have done to atria when they've undertaken surgery, and how that impacts the way in which we might map and subsequently ablate atrial flutter when we encounter these patients. So the first patient I'd like to share with you is a 52-year-old man. A year prior to meeting him, he underwent a mitral valve repair. This was undertaken because of severe mitral regurgitation due to flail P3 with caudal rupture. His valve was repaired with a slidingplasty and a 33mm Physio 2 annuloplasty ring, and that was performed using the superior septal approach to mitral valve surgery. He has no other health issues and had no other health issues. His surgery was very successful. This is a transesophageal echo following surgery. His transthoracic images were poor. Here we can see his leaflets remain thin, pliable, not stenotic. The annuloplasty ring is well seated, and there's no mitral regurgitation or very trivial residual mitral regurgitation following the surgery. Now, I met him because he was running into trouble with recurrent organised atrial arrhythmias, and this began approximately 6 months following his surgery. He had no atrial fibrillation, including in the perioperative phase. And he continued to have episodes despite initial therapy with sotalol, and that was a little bit limited because of bradycardia, and subsequently tried with amiodarone, and that was also unsuccessful in controlling his arrhythmia. This is an example of one of his ECGs. This was some AV node blocking medical therapy, so we can expose his atrial flutter morphology. And just like to draw people's eyes to the morphology, particularly as we see it through the precordial lead. So we see a multiphasic flutter morphology here, dominantly negative in the inferior leads, and with a moderately long but not very long isoelectric period between negative deflections. So Jimmy, if the pole system's working, I'm going to ask a question about what people think the mechanism of this arrhythmia might be. Thank you. So the question is, what do people think the mechanism of this arrhythmia is most likely to be based on his past history and what we see on his ECG? The options include typical cavo-tricuspid isthmus-dependent atrial flutter, an atypical right atrial flutter, left atrial tachycardia or flutter, an arrhythmia that, based on his history and ECG, could be either originating from the left or the right atrium, or something else entirely. So are people able to submit? And I'm interested in what the participants and audience feel most likely. Okay, Jimmy, are we able to see the answers before we step on? Great, so a variety of thoughts and opinions, but most converging on the idea that this is more likely than not to be a right atrial arrhythmia. Great. So here's the activation map using the CARTO 3D system of his right atrium during tachycardia. I'll play this a couple of times so that people can see the activation pattern. We see slow conduction on the septum, turning around, passive conduction into the coronary sinus, and conduction posteriorly to anteriorly on the lateral tricuspid annulus. It should play again. again, we see activation superior on the tricuspid annulus, going from lateral to medial, and then turning around on the septum, becoming septal to lateral, more posteriorly within the right atrium. And these are some still shots highlighting where we see left-hand picture, the sort of passive activation, or the activation of the atrium posteriorly to anteriorly laterally. And on the septum, we see it really turn around with a zone of slow conduction at the superior aspect of the antatrial septum. The ablation that we undertook for this included cavotricuspid isthmus ablation and also ablation from the lateral end of a set of double potentials where it broke out and started to turn around on the lateral aspect of the right atrium down to the IVC. This current map is of sinus rhythm, showing activation beginning obviously with the sinus node, colliding at that line of ablation, coursing lateral to septal in the posterior aspect of the right atrium, and now turning around in the opposite direction on the septum with the anterior portion of the right atrium being activated medial to septal, demonstrating that we have block across that lateral right atrial line. And this just shows those again in pictures where we have this lateral right atrial line with what was a series of double potentials to here, and ablation from here to the eye, down towards the CTI line, and a CTI line across here. And for those of you who are not familiar with the superior septal approach to mitral valve surgery, I've highlighted the particular aspects that are of interest to us as electrophysiologists. So surgeons will open the right atrium parallel to the right atrioventricular groove. They'll subsequently open the interatrial septum on the fossa ovalis in a superior fashion. Both of these incisions are then joined at the midpoint between the ascending aorta, which has been reflected, and the superior vena cava. An incision is subsequently extended from this region towards the left atrial appendage. In diagrammatic form, we see from the surgeon's perspective bicaval cannulation with cannula into the SVC and IVC. The aorta has been reflected. We have an initial incision laterally across the right atrium, parallel to the atrioventricular groove. This is now reflected. We see the fossa ovalis and an incision made from the inferior portion of this across towards the left atrial appendage. Over here, this is the left atrium has been reflected, and the surgeons then have quite good views and access to the mitral valve, particularly posterior leaflets. This allows the surgeons good access to the mitral valve, but from an electrophysiology perspective, patients that have had this surgery have a greater potential for right rather than left atrial macro-reentrant arrhythmias. And they also have a possibility of developing sinus node dysfunction, as the lateral right atrial incision can divide the sinoatrial artery, also called the conus branch of the right coronary artery, as part of that incision, which can lead to sinus node dysfunction. So moving on to my second case, and this is a 69-year-old man, and he had cardiac surgery 12 years before I first met him. This was because of severe bicuspid aortic stenosis, and that was his main driver for surgery. He also had a small secundum ASD, although his right heart was essentially normal, mildly dilated and dysfunctional. He had paroxysmal atrial fibrillation, hadn't been tried on medical therapy at that stage, and he had bystander but significant coronary artery disease, no angina. So he underwent quite a significant operation with a Medtronic mosaic aortic valve replacement, ASD closure via a superior right atriotomy, a Lima graft to his left anterior descending coronary artery, a cryosurgical pulmonary vein isolation, and his left atrial appendage was sutured close. In addition, 2 years following this surgery, he was diagnosed with renal cell carcinoma and had nephrectomy. He had no recurrence following that and has mild chronic renal dysfunction with no other comorbidities and living very well. When I met him, he had had 3 hospital admissions due to organised atrial arrhythmia over a short period of time. Sotalol hadn't been tolerated due to symptomatic sinus bradycardia at relatively low doses. And due to its side effect profile, he wasn't interested in taking amiodarone. So for those reasons, we elected to bring him to the EP laboratory for mapping. This is an example of his ECG, again with some AV node blocking medical therapy on board in order to expose his P wave morphology, his flutter wave morphology. Here we see much more of an isoelectric period with very small flutter waves present. Isoelectric in V1 and positive throughout the rest of the precordium, and isoelectric to positive in the inferior leads as well as lead 1. So like before, I'll ask the same question regarding what participants feel the most likely potential mechanism for this could be. And this includes, so Jimmy, thank you. So participants can consider whether they feel the mechanism of this arrhythmia is most likely to represent typical CTI flutter, an atypical right atrial flutter, left atrial tachycardia or flutter. It could be left or right atrial, or perhaps something else entirely. This man's had a lot more going on in terms of his atrium than the last. So I'll give people a moment just to consider that and put their questions in. And Jimmy, if you could show us the participants' opinions and feelings based on what they've seen so far. So that's really interesting, and so I must say I set this case up, and in my mind I thought this could be left or right atrial myself, with the perception of, gosh, he's had cryo PVI before. We know that surgeons often, because of their inability to determine and prove that they have block across their lines, they could leave macro reentrant substrate. He's got right atrial substrate in the form of the atriotomy. But yes, some of the arrhythmia that we see looks very left atrial on the ECG. So in my mind, I thought this could be either. I will show the right atrial map only because it plays better. The left atrium wasn't involved and wasn't the etiology here, although I mapped both atria at the same time. This is the example, this is the activation map of his right atrium using the the precision system in HD grid as the mapping catheter with Sparkle and isochrones. What we see is a fairly complex arrhythmia, and I'll let this play a couple of times that people can observe it. Really what we're seeing is anterior to posterior activation across the lateral aspect of the right atrium. We're also seeing activation coursing inferiorly from that more lateral aspect of the right atrium. And when we come around to the septum, we see that the septum is activated in a bidirectional fashion, would be how I see it, from both from both superior and inferior directions. The zone of slow conduction is clearly in this more posterior aspect of the left atrium, as we can see here with isochronal crowding and slowing of the Sparkle map. And in this particular case, we undertook entrainment mapping, and this zone of crowding was in the circuit and elsewhere, particularly on the CTI, was out of the circuit. So as an ablation strategy for this, we evaluated for double potentials, looking for the site of the right atriotomy, and that was identified high and lateral to the right atrial appendage. An ablation strategy here included a CTI line, given the likely mechanisms involved, and also a line from those double potentials down through this zone of convergence of colour down to the IVC. Now, the reason we didn't undertake ablation at this more posterior area where we had much more obvious isochronal crowding and slowing of conduction was because these blue dots represent sites of phrenic nerve capture. And I tend to try and stay a couple of centimetres away from areas where I can capture the phrenic nerve. If I couldn't capture phrenic nerve down here, then a line of ablation from the end of the double potentials down to this area through that zone would have been my preferred method, but it ended up coming slightly anterior to that because of that region of phrenic capture. So in conclusions, I've really spoken about anatomical understanding and that knowing what the surgeons have undertaken in terms of atriotomy scars really does advance our ability to map and understand flutter mechanisms. If a superior septal approach has been used for mitral valve surgery, the right atrium is the most common location for atrial flutter and be a very reasonable place to map in the first instance. When a lateral right atriotomy scar has been, is present and acts as the anatomical barrier or substrate for atrial flutter, a strategy of ablation from that area or the lateral aspect of that down to the IVC, I think should be considered in the first instance to try and prevent ablation in and around the sinus node, to try and prevent isolation of the sinus node, and also because I tend to find catheter stability in that region a little bit more straightforward as well as coming from, say, the appendage superiorly towards the SVC. So I'd like to thank the organisers once again, and obviously any questions and debate about what we've seen and strategies in terms of whether other people might have managed these differently.
Great. No, I think it's great. Fapo, you have a comment, please?
Yeah. Thanks for Martin for fantastic case, and it's my personal opinion. It's my personal opinion for this case, for the second case, because usually for the surgical flutters of the right atrium, it's usually owing to the cut down of the surgical during the procedure. So it means that actually you didn't need to afraid of the threatening nerve, because you didn't need to cut, you didn't to ablate the upper portion of the right atrium, because you only need to ablate the lower portion of the cut down region to the IVC. I have no idea about the, how about the opinion for Kyoko?
Yeah, usually because there's a region of the double potential, that means it's already blocked. So I would have extended from the lower end to the IVC, but I usually try to pace, and if it is, you know, if you are able to capture, maybe add some lesion, but most of the time the block line usually stays blocked. So.
Yeah, because in our group usually that we will did the ablation from the incision lines, which are with the presence of the double potentials to the IVC. That is usually the way that we did, because usually that that is the obstacle for the just like anatomic obstacles for the re-entry circuit between the incision lines as well as the IVC. So we frequently draw the lines from the insertion lines to the IVC only. But we didn't be afraid of the threatening of injury, because we didn't do ablation of the upper portions. Okay.
So you would, so you don't pace for phrenic nerve, or you don't look for it, or you just go ahead and proceed?
Yeah, because usually the ablation line will be lower, because the surgeon usually cut down at the APHRS or at the very low portion. So therefore, for a threatening insertion, that usually will be at the higher positions. So therefore,
in this particular case, though, the surgeon made their incision quite high in the atrium, essentially just underneath the atrial appendage.
But for example, just like VT ablations, we didn't do ablation at the outer loop. For example, just like we usually will do that the isthmus. It's a similar hypothesis for the right atrium. For the upper portion of the right atrium, of course, you could do a linear ablation from the incision line to the SVC, but we consider this to be the outer loop.
Yeah, sure.
Okay. I think because of the interest of time, we have to move on. We
Yeah.
have probably
Sorry
25
for
minutes discussion at the end of the
yeah,
session.
sorry,
So
sorry
yeah,
for my
Dr. Martin, thank you very much for the great
Thank
talk.
you.
So I take over. So now I'd like
Yes.
to introduce, oh, I lost my, I'm sorry. Yeah, I lost my, yes. I'd like to introduce Dr. Kumar Narayanan from India. Dr. Kumar is a cardiologist and an EP at Medicover Hospitals, Hyderabad. It's a beautiful area, India, and the chair of the APHRS Young EP Subcommittee. He's formerly trained in a clinical cardiac EP from Cedars-Sinai Medical Center, LA, and a fellow of the Heart Rhythm Society. His research interest includes sudden cardiac death, primary prevention ICD utilization, epidemiology of atrial fibrillation, and rheumatic heart disease research. He collaborates with the Paris Descartes University on cardiac arrhythmia research. Dr. Narayanan, please.
Thank you so much, and very happy to have this opportunity to present. I'm going to now shift gears a little bit and talk about a little more of classical EP and less 3D mapping. So this is basically a couple of cases. Again, we'll go based on the time. So I hope you're all able to see my screen. So let me move on to the first case. So I've kind of titled this as what is participating. So we'll try to unravel the mechanism of the arrhythmia as we go along. So this is a 48-year-old female hypertensive, hypothyroid, taking medications, who has been having very recurrent and troublesome palpitations over several years. And before she came to our center, she had already undergone ablation twice, once 6 years back, and then again 4 years back. And she had had recurrent symptoms despite that. And what was even more intriguing was that the diagnosis in the first instance was AVNRT, and in the second instance, the note said that what had been ablated was a right atrial tachycardia. And so that was confusing enough. And then she still had recurrence. And what was striking was that despite the different kinds of diagnosis she had had, all the available tachycardia ECGs looked exactly the same. And I'll just show you that. The echocardiogram, the heart was structurally normal, and she was symptomatic despite taking metoprolol and flecainide. So was the diagnosis AVNRT? Was it atrial tachycardia? What was it going to be? So this was the ECG. All of them showed exactly the same pattern. And I would like the audience to kind of go over this, and you're seeing here a very regular tachycardia. It looks a little broadish, the QRS, and you can see that the morphology is a left bundle branch block morphology. So you have, in a sense, kind of a regular white QRS tachycardia with a left bundle morphology, and you don't really have a high yield clue such as AV dissociation here to be able to conclude whether there's going to be VT or SVT. So just again, more for the benefit of the young EPs in the audience. So whenever you have a little broad looking QRS, you're thinking either in terms of VT, or you're going to think in terms of SVT with aberrancy, or you have the possibility of a pre-excited tachycardia. Now, it's always important to keep the sinus ECG in mind. Something I always tell my fellows that they should be looking at any tachycardia ECG in conjunction with the sinus ECG. And here you can see the sinus ECG is fairly unremarkable. There is no obvious pre-excitation and looks quite okay. So this patient with prior two ablations was taken to the EP lab. So here is the basic baseline situation, normal AH and HV intervals. And here we are pacing from the right ventricle, little basal aspect. And here you can see the arrangement of the coronary sinus electrograms from proximal to distal. And we can see pretty much that the activation, as we call it, is concentric, with his atrium signal being fairly early, activation being proximal to distal. So there is no eccentric atrial activation. And we also found that the conduction from the ventricle to the atrium was also decremental, suggesting that it was AV nodal conduction. So as we were doing some programmed ventricular stimulation to look at the VA conduction, we initiated the clinical tachycardia. And you can see here the extra stimulus from the V initiating the clinical tachycardia with the similar left bundle morphology. And I've not shown this, but the 12 lead of this was pretty much similar to what the clinical tachycardia which she had. And as I said, we need to now keep in mind these three possibilities. So here's the termination of the tachycardia again to help us. So can this be SVT with aberrancy? Now for SVT with aberrancy, the principle which we need to keep in mind is that your HV should either be normal as in sinus rhythm, or sometimes it could potentially be prolonged. And now you can see very nicely with the termination of the tachycardia, the hiss comes out, which is kind of hiding and buried within the QRS during the time of the tachycardia, telling you that the HV was kind of almost little negative. It was about -20 during the tachycardia. Now this effectively rules out a usual type of aberrancy and leaves you with two possibilities of either a VT or a pre-excited tachycardia. So let's look at the next thing which we did, which is the atrial pacing. And we did continuous atrial pacing. And you can see the beginning of the atrial pacing here. And then look at the interesting phenomenon which happens as we progressively pace the atrium faster. So there are three important things of note here. Number one, you can see on the surface ECG that the QRS is gradually becoming wider and wider. It's a progressive widening of the QRS. Number two, you can see that the AH interval and consequently, therefore, the AV interval is also gradually prolonging. And thirdly, you can see that the HV interval is progressively shortening, or in other words, the His is moving into the QRS. So this tells you that the broad QRS which you're seeing is brought on by atrial pacing, which is much more in favor of a pre-excitation. And secondly, very interestingly, unlike a usual pathway which will not decrement, here the AV interval is prolonging consequently, even as the degree of pre-excitation is increasing, suggesting to you that this is a decrementally conducting accessory pathway. We also looked at how fast this particular pathway can conduct, and we can see that we are able to have one-to-one conduction all the way down to a cycle length of 230 milliseconds. It's fairly a fairly rapidly conducting pathway in an antegrade direction. So I think when we look at these three aspects together, a left bundle branch like morphology and a decrementally conducting accessory pathway, then you begin to think in terms of the Maheim variant of accessory pathways, the original description being those of nodoventricular and nodofascicular pathways, and subsequently the description of the atriofascicular decremental accessory pathway, which probably is the most frequently clinically encountered. The other two variants are much rarer. Now, as we got to this stage, we then performed atrial programmed extra stimulation, and then we induced a second tachycardia, which is little more, which is basically a narrow QRS tachycardia. And two things which you can see here is that the tachycardia starts with a abrupt AH prolongation, and number two, you can see how the V and A pretty much line up with each other, both of which would make you immediately think in terms of a typical AV nodal reentrant tachycardia. Of course, you would also should do an entrainment to further prove this. And here is the termination of this particular tachycardia. So this narrow QRS tachycardia we had not seen in her clinical ECGs so far. So here it terminates with a V, and here you can see during the tachycardia itself, a fairly long AH interval and a normal looking HV interval. So we had further proof of the presence of a dual AV node physiology, where we have the so-called AH jump with an abrupt prolongation of the AH interval, and also a typical nodal atrial echo. So we had, again, supportive evidence in the presence of a dual AV nodal physiology. And now, as we are continuing the atrial programmed extra stimulation, we are back to tachycardia number 1, which is your left bundle tachycardia. And here you can see that the VA is a little longer. We measured this VA out to be about 100 milliseconds, whereas the VA with the narrow QRS tachycardia was about 25 to 30 milliseconds. So here's the tachycardia number 1. So we have already established that by atrial pacing that we have the presence of a decrementally conducting axillary pathway, and we're thinking in terms of a Mahidol variant. So let's sort that out a little more in detail here. So here we pushed our ablation catheter and put it at the RV apex. And I want you to appreciate here that the activation at the ventricular activation at the right ventricular apex is a little earlier. And you can see that his catheter is closer to the base of the RV. And this is a little earlier, telling you that during the broad QRS morphology, the activation at the RV apex is earlier as compared to the basal RV. So when we look at the described atriofascicular pathway, what has been described is an origin from the lateral right atrium, which is inserting distally into the distal end of the right bundle, or you could also have a nodofascicular variant where you're having the origin from below the AV node, which is inserting distally into the RV. So either way, you're going to have, as opposed to a typical AV, you're going to have an activation which is much earlier at the RV apex as compared to the RV base. So that's one more feature which you're able to note. The question here, though, is with this pathway, you could potentially have two possibilities. You could have what we call a true antidromic tachycardia, where you have the antegrade limb of the circuit via the axillary pathway and a retrograde up the AV node. Or it's possible that you could have another tachycardia, such as an AVNRT, where the circuit is just localized right here, but you're just having a passive or bystander activation of the atriofascicular axillary pathway. So which of the two is exactly going on here? So just like in a narrow QRS tachycardia, you would like to give a PVC during the SVT. During a broad QRS tachycardia, a PAC or an atrial premature complex is a good idea to give. It can help us understand a few things. So here we are trying to give a late PAC, and here we have a few measurements, and you can see that after the PAC, the next ventricular beat is advanced a little bit. And we can also make out that the subsequent atrial beat is also a little advanced. So when we look at the sum of the preceding two atrial beats and then the next two atrial beats after the premature complex, we can see that it is advanced as well. So the PAC the V is able to pull in the next A, and the tachycardia continues. So it tells you that the A is able to affect the V, which is very unlikely in a VT. So this helps you to, this makes the diagnosis of a VT very unlikely. Number two, it also tells you that the V is linked to the A, and it's able to drive the A, again making atrial tachycardia less likely in this situation. However, can we conclude from this that it is an antidromic tachycardia via the axillary pathway? Before we can do that, we need to look at an important thing, and that is whether the PAC was delivered during the refractoriness of the AV node or not. And here, for that, we need to look at the A to A on the His channel, and you can see that this PAC actually pulled in the atrium at the septal level also. So this was not a PAC which was delivered at AV nodal refractoriness. And therefore, this PAC could very well utilize the AV node itself to pull in the next A. And therefore, this does not conclusively prove the participation of the accessory pathway in the circuit. So on the other hand, when we give a PAC which does not advance the septal A, we see that we are unable to advance the tachycardia circuit. So, and this was done a couple of times when the septal A was not advanced, the tachycardia circuit was not advanced. Of course, here, an important point to remember is that this should really be done from the lateral right atrium when we are dealing with an atriovesicular circuit. Unfortunately, in this case, the right atrial catheter was not there, which could also partly explain the inability to advance the V itself in this case. The second maneuver which would be useful is to entrain from the RV apex. So we mentioned the circuit inserting at the RV apex, and we should expect when we entrain from the RV apex a short post-pacing interval. And here we had a post-pacing interval of about 400 milliseconds as compared to a tachycardia cycle length of 340, which to me is a little on the longer side, again suggesting to me that the bypass tract is not actively participating during the broad QRS tachycardia. The last thing which just tended to happen is that during one instance when the patient had a run of the narrow QRS tachycardia, we could see as the tachycardia was going along a progressive fusion developing with the QRS gradually broadening. The presence of this kind of a fusion also tells you that the AVNRT tends to then utilize the bystander accessory pathway on a variable basis during the actual run of the tachycardia. So we anyway went ahead and decided to map the pathway itself, and we mapped the lateral right atrium at about 9 o'clock to between 9 and 10 on the tricuspid annulus. We found these very interesting signals, which some people have referred to as probably the pathway or the M potential. And we ablated, we decided to ablate during tachycardia, during the broad QRS tachycardia, just to kind of see what is going to happen. And this is the response we observed when we ablated during the tachycardia itself. And you can see here that about 8 seconds after the onset of RF, you lose the broad QRS, and then without the change in the atrial cycle length, it smoothly transitions to the narrow QRS tachycardia. And this again, the absolute lack of change in cycle length with this transition also, and the lack of any change in activation sequence strongly argues that the pathway was more likely to be a bystander during this during the broad QRS tachycardia. So we basically completed the ablation at the lateral tricuspid annulus, and after that you can see that when we rapidly pace the atrium, we are unable to get the progressive pre-excitation which we noted earlier. But with programmed stimulation, we did have the second tachycardia inducible, which is the AV nodal reentry, and therefore we went ahead and then completed a slow pathway ablation at the inferior Cox triangle, getting some junctional rhythm during the ablation, and then subsequently we were unable to induce any further tachycardia, neither broad QRS nor narrow QRS. So to summarize, differentiating true antidromic tachycardia from a bystander activation can be sometimes challenging, and you need to perform some systematic maneuvers in order to kind of sort these things out. So I could maybe take just a minute or two, a very short second case with just one important message, and I have termed it to ablate or not to ablate. This is a 32-year-old female with no comorbidities who came with on and off palpitations, but she had no documented SVT or arrhythmia. but the cardiologist had said that she has WPW syndrome and therefore needs to be ablated. So this is the baseline ECG. Now you can have a look and see that there is a kind of subtle pre-excitation. You can see a short PR, a suggestion of a delta wave, and also a little abrupt transition in V2. So where would this pathway be possibly located? Now we have different types of complex algorithms now, and here you can see the negative, potentially negative delta in V1, fairly positive waves in lead 2 and AVF. So it is a little concerning for antro or a mid-septal location here, and you're worried, especially in a younger patient, whether this could be located a little close to the conduction system. So firstly, we confirm that there is indeed pre-excitation. So you can see this very sharp signal, which is the H signal, and the HV is about 0 here. So there is pre-excitation. And the second question is that, is this capable of conducting retrograde? And we found that at baseline, while there was no VA conduction, we did have VA conduction on isoprendlin, and then it is still possible that this could be participant in a supraventricular tachycardia. Now, however, despite a lot of aggressive pacing maneuvers, we found that there was no inducible SVT. So then the next question to ask is the APHRS pathway capable of rapid antegrade conduction with a potential risk of pre-excited AFib in the future, which would possibly be a reason to ablate? And this is the key tracing which I want to show you from this particular case, where we did progressively rapid atrial pacing, 460 milliseconds, 360 milliseconds, and then 250 milliseconds. And you can see that there is one-to-one conduction all the way down to 250 milliseconds. So a fairly rapid conduction. So here the question is, should we now take this forward? There is some VA conduction, but no SVT inducible. There is antegrade conduction up to 50 milliseconds. So the question is, should we ablate, especially considering the location of this pathway? And the key observation here is that though there is one-to-one conduction, the important thing is that the degree of pre-excitation is fixed here, and there is no change in QRS morphology. We have all seen the usual type of accessory pathways where when they conduct one-on-one, the faster you pace, the more it goes down the accessory pathway, and therefore your degree of pre-excitation should increase more and more, and your HV should become even shorter or more negative. And here you can see that the morphology is unchanged, and secondly, the HV is also fixed no matter how fast you're pacing the atrium. And this kind of a feature with a fixed HV and fixed degree of pre-excitation at all atrial cycle lengths is basically diagnostic of a fascicular-ventricular accessory pathway. And a fascicular-ventricular accessory pathway is a very unique kind of a pathway. You can now see it here outlined in this is dark blue, which is basically from sometimes even the proximal bundle, which is inserting into the ventricular myocardium. So today, in these two cases, we have seen two different types of pathways. The first one, an atriofascicular accessory pathway inserting into a distal conduction system. Here again, another type of accessory pathway, which is again involving the conduction system in the sense that it's originating from close to the conduction system and inserting into the ventricle. The important thing with the fascicular ventricular pathway is that it has a benign prognosis. It's not implicated in any arrhythmia, and therefore we need to be careful to recognize it and then to avoid ablation in this situation. So sometimes it's also important to know when not to ablate. So I will end with that and open it up to the comments from the chairpersons. Thank you very much.
Great, Kumar. Thank you very much. It was a wonderful lecture. The first case you presented, the case with the Mahaim, like bystander Mahaim. Normally, which one do you ablate first? I thought it probably because the entrainment showed it's a bystander. I think you could ablate like a slow pathway first, and then what to do with the Mahaim pathway, right?
Yeah, I agree.
Yeah.
I think that should have been the logical way to go.
But the thing you demonstrated, like ablating the Mahaim during the tachycardia, was really confirming that the bystander Mahaim still tachycardia goes on with the cycle length stable. So that was very nice. A good teaching case, I think.
Yes, I think it was. I don't know why I chose to chase the pathway first, but it did turn out that way. And as you said, when I saw the transition, I realized that it's a very very nice thing to see and appreciate the fact that it's a bystander.
Yes. So I think we'll be open to the question, right? Tachapong, you want to take over, or that for the participants, you're more than welcome to ask questions in any speakers. So we have probably like 15 or 10 minutes to have your questions.
Yes, we have about that much time to talk about things. So I guess for now, I don't see any question coming in yet. I guess let's talk about having, yes, please start.
Yeah, I was wondering, I have a question to Andrew. Nice case, I think you showed in the first, that looks like, I think we assumed that tachycardia, the flutter was atypical right atrial flutter, based on the morphology of the P wave during the tachycardia, but the activation you showed us with a 3D mapping it's a clockwise atrial flutter. I wonder, did it terminate with a CTI, or I guess because it's a very complex, like atrial incision, usually when you ablate the CTI, the tachycardia shift to the different tachycardia, and that way probably you ablate it like along the atriotomy scar. What was the case?
Yes, so the first part of the ablation was to the CTI line, and the cycle length did step out by about 40 milliseconds as part of doing that. And the second component was from the lateral aspect of that atriotomy down to the CTI IVC area, and that was when we terminated tachycardia.
So you think initially it was like a double loop tachycardia, one being a dominant, and once you ablate the CTI, it shifted to the non-dominant atrial tachycardia, or I think the way
I think so. In my mind, I think these sorts of arrhythmias you can alter and change rather than necessarily having a dominant or a non-dominant. You can have components that were participating in the circuit, and by doing linear sets like a CTI, you have components that are no longer participating in the circuit. But as long as you still have that zone of slow conduction and enough atrial mass for the tachycardia to turn around, you can then have it participate in other parts of the atrium. And I think that's what happened in this situation.
Yep, great. Tachapong, I think we have 4 questions from the audience.
Yes, so I guess first from Dr. Suchit, he's talking about if his A is pulled by the PAC, if it was going through the AV node, I guess, pull the next V, then the next V morphology should change. So it should be going through the pathway, and the pathway is part of the circuit. I guess this refers to you, Kumar.
Yeah, so that's a good question. So the way I think about it is that the conduction is going down both. So I think that is what is happening during the actual tachycardia as well, that you have a kind of a fusion between the pathway and the AV node. So unless we ensure by not advancing the septal A that we have made it impossible for the conduction to go down the AV node, then we cannot be sure that even though part of the conduction may have gone down the axillary pathway, the advancement may be because some part was activated early via the AV node itself. So I think the morphology need not completely change because there is still part of the conduction going down the axillary pathway.
Great, Kumar. That was a great question. Kyoko, do you have any other comments on that?
No, I think you're right. I think I agree with Kumar. Yep.
All right. So I guess next question is from Dr. Chung from Nanjing. This is, I think, for Fapo. What about strategy for index ablation for ARVC patients? Fapo? Wait, are you there?
Yeah, hello.
There. Yep.
Yes, okay.
For ARVC ablation strategy, yeah, we intended to do the epicardial punctures and as well as the epicardial mapping, try to find the, currently we try to figure out all the circuit as possible if the VT is mappable. However, if for some patients if the VT was not mappable, that we will try to do the substrate homogenization for those cases. But I believe that for the majority of the ARVC cases, that because that is the right ventricle environment, if the left ventricle function is preserved, that we still could map the VT.
Kyoko, what's yours?
I usually try to look on the endocardium, and I personally, I find it a little bit challenging to ablate through the fat. I know it's more dominant on the epicardial surface, but a lot of the time, you can't quite get to the circuit from epicardium. In contrast, from endocardium, you have so thin myocardium. I would feel more comfortable doing ablation from endocardium for especially the ARVC patient, not in a non-ischemic cardiomyopathy, but ARVC patient. I prefer to do endocardium as much as possible.
Yeah,
that's a preference. those are the
Andrew,
very
anything?
Yeah.
Yeah.
No, I guess. Yes, Andrew.
Our group tend to take an approach of medical therapy for ventricular arrhythmias in the first instance, and if people fail or don't have success with that, then we tend to take a combination endo-epi approach for first procedures for ARVC, particularly for that particular substrate. It'd be fair to say that we in Auckland maybe only do 2 or 3 ablations a year for ARVC, so it's not a common procedure for us, but our usual approach would be to take an endo-epi approach.
I'll say, I guess, since we don't give heparin when we map the RV, I guess I wait until we have to do epicardial, then we go epicardial, but I guess I won't go ahead and do it from the beginning. Kumar, any comment?
Yeah, I mean, for me, the same. We don't do much of the ARVC here. So I think the approach I've heard of is like what Andrew said. It's more of endo-epi combined, but the threshold to go epicardial is probably lower in that in the particular case of ARVC.
Okay, I guess next is for Andrew. The question is from Dr. Udada. Udada, he's asking, as you can see there, what are the atrial arrhythmias seen post-Fontan? How do you approach them?
So thanks for the question. I wondered if I might be able to answer that by sharing a screenshot as well. So I thought that might be coming. Is this picture up?
Yep.
It depends. In my opinion, it depends on the nature of the Fontan surgery. The classic Fontan for us in Auckland, if patients are having atrial arrhythmias and with a classic Fontan, we would see that as an indication to consider Fontan conversion to a more modern extracardiac conduit. And really, we undertake ablations for these patients where they're felt not to be candidates for that, or if they're going to go down a transplantation route. That said, most of the atrial arrhythmias that we see in the classic Fontan are either a variant of CTI flutter or focal tachycardias. So in our practice in Auckland, most of the atrial arrhythmias that we undertake ablations for in the Fontan patients are in the lateral tunnel. And our practice was well, our surgeon's practice was to undertake this procedure from about the late 1980s through to about the turn of the century, maybe just shortly after that. And since then, the extracardiac conduit, which fortunately has very few atrial arrhythmias in our experience. Those with the lateral tunnel, again, these seem to be dominantly CTI-dependent atrial flutter circuits. Puncturing from the conduit into the common atrium is an important component of the procedure. I tend to undertake that rather than going via a retro-aortic approach. I think catheter manipulation is more straightforward, and I find that sufficiently safe. Typically, these patients may well have hypoplastic right ventricles, so identifying the rudimentary tricuspid annulus or the annulus at that point can be challenging, but undertaking ablation from that back to the conduit itself, and then within the conduit from there down to the IVC tends to be a good strategy for treating CTI-dependent, so-called CTI-dependent atrial flutters, and that seems to be the most common thing. The other thing we need to be wary of in these patients is because of their often underdeveloped AV valve annuli, accessory pathways are not an uncommon mechanism for tachycardia here as well, and it's something to be mindful of, as often we have an incomplete catheter set because of access to the chambers, and it's something to be thoughtful of when we undertake diagnostic procedures, that they're not necessarily atrial arrhythmias, but might well be AVRT, and we just need to be mindful of that.
Hey, Andrew, I have a question. What do you do for like image integration, or what imaging technique do you do like before, during the procedure for these type of congenital heart? Yeah,
so we have very good support by our CT colleagues. So CT is our imaging integration modality of choice here. And we'll bring that into our 3D models. I personally quite like, for these more complex cases, using CARTO in the UniView module. For these patients, I'll take a pigtail catheter and undertake an atriogram essentially in 40 to 50 mils of contrast in LAO and RAO projections, and bring that into the 3D mapping system. And you can use UniView not just for a still background picture to reduce fluoroscopy, but also as a playback as part of your undertaking mapping to understand really where you have anatomy and where you don't have anatomy. And if you do a levo phase run, then you can understand anatomy in the opposite chamber, so the pulmonary venous atrium as well.
Great. I have not done a lot of these things. I don't even remember. I did a few. Kyoko, you have any?
I haven't.
Tricks?
Personally, I don't have too much experience with the Fontaine. You guys are lucky. All right.
Papa, anything? Wait, I guess there's another. Okay, I guess the next question. Where did the next question go? It has to do with, I guess, FAPO case. The first case, where was the initial ablation done? You said RV endocardium was normal, no scar. That's from Dr. Chandrasekaran. How are you?
Could I be here? For the first case, that definitely that the endocardium was not. I think only very tiny part of the circuit was involved in the right endocardium, because you could see that either for the endocardium or the endocardium, both show the centrifugal pattern of the activation, which means that it's the majority of the circuit should be the intramural. So we could only record a very tiny point that with the diastolic activity, just as what we showed for the first case, that you could see a very tiny potential with the diastolic activity that at the sites corresponding to the endocardial side, we have the very good entrainment. So I think for the cases that for that case, that is the majority of the isthmus should be the intramural. But we could only we could only record the very tiny component with the epicardial exit for the VD isthmus. It's very lucky that we could also record that, and we could terminate the VD at that site.
Okay, I guess we have two more questions. I guess we'll end a little bit slightly late, so quick answer. This one is from Dr. Sujit. and it's for Andrew. Do you ablate just the circuit? Do you ablate any like potential region circuit when you do these congenital things?
So I think it'd be fair to say that some of these cases can take some time, and some of the patients have hemodynamic issues and compromise. In the first instance, my practice would be to normally, ordinarily ablate the tachycardia mechanism that we can induce or is present at the time. If, depending on the nature of the patient and anatomy, so if it's, say, a transposition atrial switch like a mustard or a classical Fontan, if the patient's condition allows it and CTI wasn't part of the initial tachycardia ablation strategy, then I would have a fairly low threshold to undertake cavo-tricuspid isthmus ablation, in addition, providing the patient's overall clinical state would allow that extension to the procedure.
All right, great. I guess last one from Dr. Raza to Kyoko. What about ICD implant for this reentry, bundle branch reentry VT?
Yeah, I think it depends on the etiology of the disease. Say you go for the EP, for the bundle branch reentry, but again, if your diagnosis is bundle branch reentry, you can do, at the end of the procedure, you do a program stimulation to induce some other VT. If the patient develop like substrate-based VT, you can still ablate, but I think the ejection fraction matters. If the EF is lower than 40%, I usually prefer like putting ICD, not depending on the provocation of the VT. If it is ischemic VT, I may consider without the ICD if nothing is inducible, but with non-ischemic, it's a little bit difficult to depend on inducibility of the VT. Any other thoughts?
I'm ICD guy.
I just have a short question for the Kyoko, for the very interesting question, because currently we think that we didn't have a very solid evidence for the ICD implantation in those with the non-ischemic cardiomyopathy, right? So, what is the strategy for those if you have the non-sustained VT in one patient with the, for example, just the ejection fraction to be the 35 to the 40, just in between, then you have the non-sustained VT, for example, just like 3, 4, 6-bit continuity activities, then what is your strategy?
I usually try to give them ICD. I think non-ischemic cardiomyopathy has a poor prognosis compared to the ischemic cardiomyopathy patient. And the other thing I usually use is try to do a delayed enhanced contrast MRI. If the amount of the delayed enhanced area is high, probably the ICD would protect them. Yeah, that's how I usually practice. Kumar, any other thoughts?
Yeah, I think it's the MRI is being used increasingly now, and I think we are also recognizing that non-ischemic cardiomyopathy is really more a heterogeneous is a group of conditions rather than a single condition, which is why I think the trials are also throwing up little complex results. I think CRT has an important role. I think patients who are good candidates for CRT, they tend to do well, and some of them probably the ICD will not make a difference, and there are some studies coming out to that effect now. So I think you're right that if there is a lot of scar, if the patient is not a good candidate for a CRT, and especially I think if there is non-sustained VT, it's kind of showing you that it's threatening to come out. So I think we should probably go ahead with an ICD in those cases. Yes.
Right, Tachapong?
All right, I guess it's time to close. Thank you very much, everyone. Kumar, thank you for arranging all these webinars. Thanks all the panels. Absolutely, thanks the panelists for joining us, and all the audience. Young EP groups are very important for APHRS. You guys are going to be the future of APHRS, so please join us. And then again, if anyone has interesting case, contact Kumar over there. He will be helping us with arranging and maybe doing this every weekend. Maybe you don't want to do that, but this is very great. This is great. Kyoko?
Thank you so much,
you.
Dr. Tachapong. So on behalf of the Young EP subcommittee, I just want to thank our chairpersons, Dr. Tachapong and Professor Soejima again. Special thanks to Dr. Andrew Martin and Dr. Chung for coming forward with such very interesting cases. So as our president has said, we hope to continue this on an ongoing basis. And as he said, you know, the young EPs from the different countries, Asia Pacific, should come forward, and they will be happy to, you know, involve them and to do some interesting case presentations. And all of us should learn. That's the objective at the end of the day. So thanks very much to one and all. And thank you, Jimmy, for the organization. Great organization.
Thank you.
Great.
Thank you very much.
Some 90
Thank you.
people. Great.
Have
Thank
a
you.
nice
Bye.
weekend. Stay safe.
Take care, everyone.